Good afternoon.
Good afternoon, ma'am.
Good afternoon.
Good afternoon, ma'am.
So let's wait for all students came. Good afternoon, students.
Good afternoon.
So we have 5 minutes to wait for all students came, okay? All students came?
भाई क्या हो रहा है? Fuck. विनय, बेबी, क्या हो रहा
Hi,
है?
what happened? Close your voice.
Close your
Oh.
microphone.
Microphone, yes. Because you are audible. One moment, I will take photo of your present students. So all students came? Very good. One moment. Can you see the screen?
Yes, ma'am.
Yes, ma'am.
Okay. So today is lecture number 3, syndromes in pathology of the digestive system. So we will talk about, one moment. Please invite colleagues. You should come on time, not be late. So, people in waiting room again. Today we will talk about syndrome of gastrointestinal tract, the hepatobiliary syndromes, coprology syndromes, and biochemical syndromes of liver pathology. So let's talk about esophagus syndromes, diseases of esophagus. Gastroesophageal reflux disease, Barrett esophagus, dysphagia, gastroesophageal motility disorders, malignant esophageal tumors, and eosinophilic esophagitis. So, anesophageal motility disorders are any medical disorders causing difficulty in swallowing, regurgitation of food, and spasm-type pain, which can be brought on by an allergic reaction to certain food. The most prominent one is dysphagia. It may be a part of CREST syndrome, refers to the 5 main features: calcinosis, Reynolds phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Classification of syndrome dysphagia. So first of all, you have to know that according to cause, it may be functional dysphagia or organic dysphagia. According to localization, it may be preesophageal dysphagia and esophageal dysphagia. According to course of dysphagia, it may be intermittent dysphagia or progressive dysphagia. Can you see the screen? Is it audible, visible, everything?
Yes,
Yes,
ma'am.
ma'am.
Okay, so let's talk about organic dysphagia. Organic dysphagia develops gradually and progresses in cancer and cicatricial stenosis of the esophagus. Solid food first passes with difficulty, then the patient feels difficulty in swallowing soft and then liquid food. When cancer tumor disintegrates, patency of esophagus may be restored almost completely. Dysphagia develops immediately in the presence of foreign body of its esophagus is burned. Dysphagia may also develop due to compression from outside by aortic aneurysm or mediastinal tumor. Let's talk about functional dysphagia. Functional dysphagia of the esophagus is explained by muscular spasm caused by reflex disorders of innervation of the esophageal muscles or by neurosis. As distinct from organic dysphagia, functional dysphagia more often occurs in paroxysm when food passes the esophagus. Sometimes solid food passes more readily than liquid. Colleagues, you can see examination to syndrome of dysphagia includes swallow study. This is usually administered by a speech therapist. They test different consistencies of food and liquid to see which cause difficulty. They may also do a video swallow test to see where the problem is. Barium swallow test, the patient swallows a barium containing liquid. Barium shows up in X-rays and helps the doctor to identify what is happening in the esophagus in more detail, especially the activity of the muscles. Endoscopy. A doctor uses a camera to look down into the esophagus. They will take a biopsy if they find something they think might be cancer. Symptoms of esophagus motility disorders. First of all, difficulty swallowing liquids or solids, dysphagia, regurgitation, heartburn, chest pain, atypical chest discomfort, vomiting, sensation of something getting stuck, and weight loss. Colleagues, here you can see X-ray examination, diagnosis.
Excuse me, ma'am.
Yes, who is waiting room?
No, ma'am. I'm saying that the slides are not changing. It's on the first slide still.
What happened?
The slides are not changing. It's still on the first slide.
Why why you didn't tell me? One moment. Why? What happened? And now?
Yes, ma'am.
Everything good?
Yeah.
Visible?
Yes, ma'am.
So I will show you previous slides, okay? So very quickly, I will show you present slides. So diseases of esophagus, difference between it is classification of dysphagia. You can take photo of this slide. It is very important slide. Difference between organic dysphagia and functional dysphagia. Examination of the patient with dysphagia syndrome. Here you can see picture. And symptoms. Is it visible now?
Yes, ma'am.
Yes, ma'am.
Okay, thank you very much. So you can see barium tapering indicates outgraft from the walls of the esophagus. Diagnosis of dysphagia is based on clinical picture confirmed by data of X-ray examination and esophagoscopy. Here you can see dysphagia causes. Diagnosis of dysphagia is based on clinical picture confirmed by data, X-ray examination, and esophagoscopy. Here again, causes which provoke dysphagia. Here, place, and here. It might be cancer sometimes. Here, barium swallow images in patients with syndrome of esophageal dysphagia caused by achalasia. Shows esophageal dilation. Here you can see esophagus dilation here and here. And here also, achalasia shows esophageal dilation. Here you can see. And secondary achalasia here and here. Here you can see barium swallow image in patient with syndrome of pre-esophageal oropharyngeal dysphagia. It might be cancer this place, can provoke changes of esophagus. It is esophagoscopy. Here you can see. Here dilated esophagus and fluid-filled esophagus. Let's talk about next syndrome. Achalasia, lower esophageal muscle does not relax enough to allow food into the stomach. Here you can see. This sphincter doesn't relax. Next syndrome is gastroesophageal reflux disease. It is chronic disease caused by periodic reflux of gastric content into the esophagus, resulting into development of reflux esophagitis, or without it, accompanied with heartburn arising more on one time a week within 6 months, and characteristic extraesophageal symptoms. So the major symptoms are heartburn and regurgitation. The patient is often overweight. Some patients are woken at night by choking as reflux fluid irritated the larynx. Variety of other features have been described, such as atypical chest pain, which may be severe and can mimic angina, and may be due to reflux-induced esophageal spasm. Others include acid laryngitis, recurrent chest infections, chronic cough, and asthma. The true relationship of these features to gastroesophageal reflux disease remains unclear. Can you see the screen, colleagues?
Yes, ma'am.
Okay. So let's continue. Etiology and pathogenesis gastroesophageal reflux disease. So let's talk about etiology and pathogenesis of gastroesophageal reflux disease. First of all, failure of inferior esophageal sphincter, reflux of stomach and duodenal content in esophagus, decrease of esophageal clearance and stomach emptying, decrease of mucous esophagus resistance, weakening of anti-reflux barrier of inferior esophageal sphincter. Stomach and duodenal syndromes, dyspeptic syndrome or functional dyspepsia, and dyskinetic syndrome. Let's talk about dyspeptic syndrome or functional dyspepsia, indigestion. Functional dyspepsia is a chronic disorder of sensation and movement peristalsis in the upper digestive tract. Peristalsis is the normal downward pumping and squeezing of the esophagus, stomach, and small intestine, which begins after swallowing. We call this disorder functional because there are no observable or measurable structural abnormalities found to explain persistent symptoms. Other terms, non-ulcer dyspepsia, pseudo-ulcer syndrome, pyloduodenal irritability, nervous dyspepsia, or gastritis. Reasons of functional dyspepsia: excessive acid secretion, inflammation of the stomach or duodenum, food allergies, lifestyle and diet influences, psychological factors, medication side effects, and Helicobacter pylori infection. Dyspeptic syndrome or functional dyspepsia. A physician forms a diagnosis of functional dyspepsia when there is no evidence of structural disease and there have been at least 3 months of one or more of the following. Birth symptom post-meal fullness, early satiation, epigastric pain, and epigastric burning. A diagnosis of functional dyspepsia is supported by the following points. The patient constant sign of dyspepsia, a pain or sensation of the discomfort located in epigastrium or midline in upper abdomen. For the last 3 months with symptoms onset at least 6 months before diagnosis are marked. The inspection of the patient including upper gastrointestinal endoscopy excluded organic diseases that are capable to explain signs. The signs of dyspepsia are not relieved after defecation or are not connected to change frequency and character of defecation. There are no symptoms of irritable bowel syndrome. Diagnostic methods of the functional dyspepsia usually include, first of all, esophagogastroduodenoscopy. Can you see, is it visible, colleagues? Is it visible?
Yes, ma'am.
Yes, ma'am.
Okay. Abdominal ultrasound to exclude pathology of pancreas, biliary tract, and liver. Clinical and biochemical analysis of blood, specifically erythrocytes and leukocytes count, erythrocyte sedimentation rate, alkaline phosphatase, glutamyl transpeptidase, aspartate aminotransferase, alanine aminotransferase, urea, and creatinine. Common analysis of feces and analysis of feces are called blood. Under the indications, it were used the X-ray inspection of a stomach, scintigraphy of the stomach, assisting to establish presence of gastroparesis, diurnal monitoring of intraesophageal pH, and electrocardiography. Next syndrome is gastritis, is a histological diagnosis. Also, it can sometimes be recognized at endoscopy. Here you can see table with type of gastritis. You can see acute gastritis, which causes of acute gastritis: aspirin, Helicobacter pylori, alcohol, drugs, severe physiological stress, burns, multi-organ failure, bile reflux following gastric surgery, and viral infections. Chronic non-specific gastritis, Helicobacter pylori infection, autoimmune and post-gastrectomy, and chronic specific forms: infections, tuberculosis, gastrointestinal disease, Crohn's disease, systemic disease, sarcoidosis, graft versus host disease, idiopathic granulomatosis gastritis. So let's talk about gastritis. It's inflammation of the gastric mucous membrane. Term gastritis should be reserved for histological documented inflammation of the gastric mucus. Prevalence of gastritis is near 40–50% of adults. So here you can see table. Colleagues, can you see the screen?
Yes.
So there are such type chronic gastritis A and chronic gastritis B. So what is the difference between them? Chronic gastritis A is characterized by autoimmune body predominant affection of the gastric mucus and gradual development gastric atrophy, achlorhydria, and achillia. Chronic gastritis type B is Helicobacter pylori related with antral predominant affection of the gastric mucus. Chronic gastritis A clinical picture includes mild syndrome of gastric dyspepsia, postprandial fullness, early satiation, nausea, putrefactive belching, poor appetite. Loss of weight may be. Vitamin B12 deficiency anemia may develop in 15–20 years because absence of intrinsic factors, gastromucoprotein. Chronic gastritis type B characterized by tendency to hyperchlorhydria in early stages, and in late stage hypochlorhydria may diffuse gastric atrophy develops. A clinical picture includes epigastric pain and burning, acid regurgitation, and increased appetite due to gastric hypersecretion. Diagnosis is supported by the detection of Helicobacter pylori in specimen of gastric biopsy or by other techniques. Diagnosis of chronic gastritis is supported by endoscopy and gastric biopsy. Diagnostic test to detect Helicobacter pylori to chronic gastritis B, biopsy, rapid urea test, urea breath test, stool antigen test, antibody testing. Diagnostic test for chronic gastritis A diagnosis, serum cobalamin level, antibody testing. Supplemental methods: study of gastric juice, pH metry, X-ray and ultrasound, gastric emptying, and electrogastrography, serum levels of the pepsinogen. Peptic ulcers of stomach and duodenum. Peptic ulcer is general chronic and relapsing disease characterized by seasonal exacerbation with ulceration of the stomach wall or the duodenum. Ulcer is defined as disruption of mucous integrity of the stomach and duodenum leading to a local defect of excavation due to active inflammation. Prevalence of peptic ulcer is near 10–12% of adults in Europe and United States. Classification of peptic ulcer. First of all, according to location, it may be gastric ulcer, it may be duodenal ulcer. According to stage of disease, it may be exacerbation or remission. According to complications of peptic ulcer, gastric, duodenal bleeding, perforated ulcer, penetrated ulcer, malignant ulcer, pyloric cicatricial stenosis. Complications of peptic ulcer. You can take photo of this slide. It is very important. Complications, hemorrhage, most common complication. Symptoms include hematemesis, passage of blood by black tarry stools, weakness, orthostatic syndrome, thirst, sweating caused by blood loss, penetration, conferring perforation. Peptic ulcer may penetrate the wall of the stomach or duodenum and enter the adjacent confined space, lesser sac or organ, pancreas, liver. Free perforation, gastric outlet obstruction, pyloric stenosis. This may be caused by scarring, spasm, inflammation associated with ulcer. Symptoms include recurrent large volume vomiting occurring more frequently at the end of the day and often at last 6 after the last meal. Persistent bloating or fullness after eating, loss of appetite also suggests gastric outlet obstruction. And stomach cancer. Stomach cancer, Helicobacter pylori is associated with adenocarcinoma intestinal type of the gastric body and antrum, but not cancer of the gastric cardia. Gastric lymphomas and mucosa-associated lymphoid tissue lymphomas have also been linked to this infection. Syndromes of the small and large intestine. Syndrome of slow evacuation of intestinal content, syndrome of accelerated evacuation of intestinal content, diarrhea, irritable bowel syndrome, syndrome of fermentative dyspepsia, putrid dyspepsia, inadequate absorption, maldigestion, and malabsorption, intestinal colic syndrome, and intestinal obstruction syndrome. So, colleagues, here you can see, let's talk about constipation. It is difficult or infrequent passage of feces, no more than 3 times a week, hardness of stool or feeling of incomplete evacuation. There are different causes of constipation. Colonic obstruction, neoplasm stricture, ischemic diverticular, inflammatory megacolon. Medications, antidepressants, irritable bowel syndrome, disorders of rectal evacuation, endocrinopathies, psychiatric disorders, neurological disorders, and generalized muscle disease. Syndrome of accelerated evacuation of intestinal content, diarrhea syndrome, is the passage of abnormally liquid or unformed stool at increased frequency, more than 3 times a day, and increased weight. Classification of diarrhea, it may be acute or chronic, it may be according to etiology, infections, drug-induced, food-related, post-surgical, inflammatory, transit-related, and psychological causes. Irritable bowel syndrome is a group of symptoms including abdominal pain and changes in the pattern of bowel movements without any evidence of underlying damage. Rome second criteria defined irritable bowel syndrome as having abdominal pain, discomfort along with at least 2 of the following 3 features. Defecation relieves pain, discomfort. Onset of pain associates with abnormal frequency of stools more than 3 times per day, or fever than 3 times per week. Onset of pain associated with a change in the form of the stool. Altered colonic motor function may result in constipation, diarrhea, or alternating constipation and diarrhea, irritable bowel syndrome. In addition, recent studies show that about 10 to 25% of patients develop symptoms of irritable bowel syndrome after episode of severe or prolonged enteric inflammation, post-infections irritable bowel syndrome. No specific laboratory or imaging test can diagnose irritable bowel syndrome. Diagnosis should be based on symptoms, that exclusion of worrisome features, and performance-specific investigations to rule out organic diseases that may present similar symptoms. So let's talk about syndrome of fermentative dyspepsia. Fermentative dyspepsia is a set of clinical symptoms due to predominance of fermentative flora of the intestine. Causes of fermentative dyspepsia are different. Deranged digestion of carbohydrates, carbohydrates intolerance, lactase deficiency, excess intake of sweet fruits and vegetables, inflammatory pathology of intestines, enterocolitis. Syndrome of fermentative dyspepsia. Clinical picture characterized by the diarrhea, 2-3 stools per day, meteorism, abdominal bloating, flatulence, pains in paraumbilical region and right lower abdomen. Feces are semi-liquid, foamy with acid smell. Coprology study detect numerous gas bubbling in feces, acid reaction of feces. Microscopy shows indigested cellulose, numerous stretch grains, amyloria, idiophilic microbes. Diagnosis of fermentative dyspepsia, typical complaints and history, data of coprology studies, acid reaction, indigested cellulose, amyloria, and idiophilic microbes. Syndrome of the putrid dyspepsia is a set of clinical symptoms due to predominance of putrefactive flora of the intestine. Causes of putrid dyspepsia are secretory hyperfunction of the stomach, chronic gastritis, accelerated intestinal transport, excess intake of protein food. Diagnosis is based on typical complaints and history. The data of coprology studies, alkaline reaction, creatorrhea, steatorrhea. Clinical picture is characterized by diarrhea, 2-3 stools per day, meteorism and flatulence, pain in paraumbilical region, epigastrium, feces, liquid dark excrements with clots of undigested food and full putrid smell. Evidence of steatorrhea might be yellow-gray color, ointment-like consistency of feces. Coprology studies show visible remains of undigested food, alkaline reaction, microscopy detects much fats, steatorrhea, muscular fibers with vivid transverse and longitudinal striation, creatorrhea. The idiophilic flora is absent. Syndrome of inadequate absorption. Maldigestion and malabsorption is a symptom complex resulting from impaired absorption of nutrients from the small bowel. Indigestion syndrome, absorption deficiency syndrome, malabsorption syndrome. Classically, maldigestion is defined as defective hydrolysis of nutrients, and malabsorption is defined as defective mucus absorption. A mechanism may be direct impairment of absorption or abnormalities of digestion that leads to impaired absorption. A malabsorption may occur for many nutrients or specific carbohydrates, fats, or micronutrients, for example, calcium, iron, cobalamin, folic acid, etc. Syndrome of maldigestion and malabsorption. So gradual wasting, symptoms of metabolic disorders of all type, progressive atrophy of subcutaneous fat and muscles, dystrophic changes of the skin, nails, hairs, and the internal organs with subsequent dysfunction. constant diarrhea with steatorrhea, creatorrhea, amylorrhea. Hypoproteinemia develops, hypocholesterolemia, hypocalcemia, and moderate hypoglycemia occur. Clinical picture and laboratory findings. First of all, symptoms of polyhypovitaminosis, characterized by osteoporosis, anemia, trophic changes in the skin, nails, progressive atrophy of the muscles, signs of polyglandular insufficiency, weakness, and acidosis and cachexia. Coprological studies reveal increased content of undigested food in the feces, increased exertion of the products of enzymic decomposition of food. Endoscopy and enterobiopsy reveals atrophic changes in the mucus of the proximal part of the small intestine. Diagnosis is based on typical clinical picture, findings, laboratory examinations. Hypoproteinemia, hypocholesterolemia, hypoglycemia, and other disorders due to malabsorption. Clinical picture and laboratory findings in maldigestion and malabsorption syndrome. Here you can see, since the walls of the small intestine absorb a great amount of various substances, different methods are used to study their absorption. There are tests with folic acid, galactose, deoxylose absorption test, casein, albumin, oleic acid, methionine, glycine, vitamin B12, so folic acid, and other substances labeled with radioactive isotopes may be used. Determination of the absorbed nutrients is based on the study of the chemical composition of food and stools during a certain period of time. Let's talk about intestinal colic syndrome. So there are three types of colic seen in adults: biliary colic, renal colic, or intestinal colic. Let's talk about biliary colic. It's often caused by gallstones. Gallstones are pieces of hardened digestive fluid called bile. This hardened fluid can form a stone-like substances and block ducts that flow from gallbladder to pancreas or liver. These blockages can cause inflammation and tenderness and lead to problems with digestion. Symptoms include abrupt pain that's located either in right side under the breastbone or more towards the center of the abdomen. The pain intensifies over time but generally doesn't last for more than few hours. Let's talk about intestinal colic. Intestinal colic is a cramp-like pain that originates in the small or large intestine. It's caused by a blockage that keeps food and liquid from passing through the body. Blockage can occur because the formation of scar tissue from previous abdominal pelvic surgery. Inflammatory intestinal disorders like Crohn's disease, impacted feces, infected diverticula, which the pouches that forms on the wall of the colon, cancerous tumors. In addition of abdominal pain, symptoms include inability to have a bowel movement or pass gas, vomiting, loss of appetite, abdominal distension. Colleagues, here you can see intestinal obstruction syndrome is a mechanical or functional obstruction of the intestines which prevents the normal movement of the product digestion. Signs and symptoms include abdominal pain, vomiting, bloating, and not passing of gas. So, intestinal obstruction syndrome. Depending on the level of obstruction, bowel obstruction can present with abdominal pain, swollen abdomen, abdominal distension, vomiting, fecal feces vomiting, and constipation. In small bowel obstruction, so there are different clinical picture in small bowel obstruction and large bowel obstruction. In small bowel obstruction, pain tends to be colicky in nature with spasm lasting a few minutes. Pain tends to be central and mid-abdominal. Vomiting may occur before constipation. But in large bowel obstruction, pain is felt lower the abdomen and the spasm lasts longer. Constipation occurs earlier and vomiting may be less prominent. Proximal obstruction of the large bowel may present a small bowel obstruction. Intestinal obstruction syndrome. The main diagnostic tools are blood test, X-ray, a CT scan, ultrasound, and biopsy. Here you can see X-ray. Radiological signs of bowel obstruction include bowel distension and presence of multiply gas fluid levels on supine and erect abdominal radiographs. Here you can see here and here and here, here and here. Syndromes of the small and large intestine. Water-soluble contrast enema. Contrast was introduced per rectum. Contrast enema or small bowel series of CT scan can be used to define the level of obstruction, whether the obstruction is partial or complete, and to help define the cause of the obstruction. Next syndrome is Crohn disease syndrome. Crohn disease is non-specific chronic transmural inflammatory disease that most commonly affect with ulceration of distal ileum and colon, but may occur in any part of the gastrointestinal tract. Diagnosis of Crohn disease is based on typical clinical picture, right lower quadrant abdominal painful mass, perineal fistulas or abscess, and X-ray findings confirmed by data of endoscopy and biopsy. Non-specific ulcerative colitis is a chronic inflammatory and ulcerative disease arising primarily in the colonic mucus of rectus sigmoid, characterized most often by bloody diarrhea. Clinical picture. Like Crohn's disease, ulcerative colitis may affect people at any age, but the age onset curve shows a bimodal distribution with a higher peak at age 15 to 30 and second smaller peak at age 50 to 70 year old. The most typical complaints is bloody diarrhea, fever, anorexia, weight loss, maybe in case of extensive active ulcerative colitis. A bloody diarrhea of varied intensity and duration is interspread with asymptomatic intervals. Let's talk about hepatobiliary syndromes. Let's talk about syndrome of biliary dyspepsia, jaundice, portal hypertension, hepatic encephalopathy, hypersplenism, hepatorenal syndrome, hepatic insufficiency, and biliary dysfunction. So let's start about talking about biliary dyspepsia syndrome. It's a set of clinical symptoms due to disordered biliary tract function and biliary reflux from duodenum to upper parts of digestive tract. Syndrome of biliary dyspepsia causes diseases of the hepatobiliary system, other parts of the digestive system, predisposing factors, intake of fatty food, inactive mode of life, hypodynamia, and rare meals. Clinical picture includes steady pain in the epigastrium and right upper quadrant of abdomen, a bitter taste in the mouth, decreased appetite, eructation, nausea, vomiting, distension of the abdomen and rumbling, constipations or diarrhea. Laboratory and instrumental examination. A test of liver biochemistries and pancreatic enzymes, ultrasonography of the liver, gallbladder, duodenal intubation and microscopy of bile, gastroduodenal endoscopy, ultrasonography assessment of gallbladder emptying. Here you can see classification of cholecystitis. Cholecystitis is inflammation of the gallbladder wall. A clinical picture of cholecystitis. In case of biliary hepatic colic, the patient complains of severe steady pain in the right upper quadrant and epigastrium, often radiating to the right scapula, right shoulder and neck, which usually develops in 1-3 hours after taking abundant, especially fat and roasted food. Nausea and vomiting are usually in biliary colic. Dyspeptic signs are also present. Bitter and metallic taste in the mouth, eructation, nausea, abdominal flatulence, and alternation of diarrhea with constipation. Disease is sometimes not attended by pain except that the patient feels heaviness in epigastrium or right hypochondrium and dyspepsia develops. A high body temperature may be in acute cholecystitis and exacerbation of chronic cholecystitis, usually subfebrile. Cholelithiasis. Cholelithiasis is a metabolic disease characterized by formation of stones in the gallbladder or less frequently in the bile ducts. So let's talk about clinical picture of cholelithiasis. First of all, typical hepatic colic, atypical pain, biliary dyspepsia, and latency cholelithiasis. Pain attack in the right hypochondrium are the most characteristic symptom of cholelithiasis. Cholangitis. Here you can see classification of cholangitis. Is inflammation of the intrahepatic and extrahepatic bile ducts. Next, syndrome of jaundice is ectatic coloration of the skin and mucus by the increased content of bilirubin in the tissues and blood. Syndrome of jaundice. Causes of jaundice include many diseases of the liver, bile ducts, blood, and diseases of other organs. Here you can see xanthelasma and jaundice sclera in patients with chronic cholestasis. Classification of jaundice according to causes. There are 3 types: prehepatic, hepatic, and posthepatic jaundice. Prehepatic jaundice is main symptom of hemolytic anemia. It can also be symptom of other diseases such as B12 deficiency anemia, malaria, bacterial endocarditis, etc. Clinical features of prehepatic jaundice. First of all, color of the skin. So, color of the skin will be lemon yellow. Skin itching is absent. Amount of unbound bilirubin in the blood is moderately increased. Bilirubin is absent from the urine, but the urine is still colored rather intensely by the markedly increased stercobilinogen and urobilinogen. Feces are intense dark due to the presence of considerable amount of stercobilinogen. Hepatic jaundice develops due to damage of the parenchyma cells, hepatocytes. Common diseases in hepatic jaundice are hepatitis, liver cirrhosis, cancer of the liver, etc. Clinical picture. First of all, color of the skin. Jaundice is typical yellow with a reddish tint. Skin itching is less frequent than in obstructive jaundice because the synthesis of bile acids by the affected liver cells is upset. Symptoms of pronounced hepatic insufficiency may develop in severe course of disease. Post-hepatic jaundice develops due to partial or complete obstruction of the common bile ducts. This occurs mostly due to compression of the ducts from the outside by growing tumors, obstruction by a stone. Colleagues, here you can see stones in gallbladder. Here is stone in gallbladder. A clinical picture of post-hepatic jaundice. First of all, color of the skin will be green and dark olive color. Bound bilirubin content in the blood may be as high as 250, 340 and more. Bound bilirubin can be found in the urine to give it brown color and bright yellow foaming. In complete obstruction bile ducts, feces become colorless, aholic. A laboratory test is syndrome of jaundice. First of all, you have to check total and bound serum bilirubin, bile pigments of urine, bilirubin, urobilinogen, and stercobilinogen of feces. So next pathology is chronic hepatitis. Represents a series of liver disorders of varying causes and severity in which hepatic inflammation and necrosis continue for at least 6 months. So first of all, clinical picture. First of all, biliary dyspepsia, jaundice, moderate enlargement and induration of the liver and spleen, asthenoneurotic syndrome, dysfunction of the liver as determined by laboratory tests. Classification of chronic hepatitis, you can do a photo of this slide. So syndrome of portal hypertension is a syndrome of increased pressure in the portal venous system. Causes of syndrome portal hypertension. Portal hypertension results from increased portal flow. In most causes, increased resistance to flow. According to etiology, 3 variants of portal hypertension are distinguished: prehepatic, hepatic, and posthepatic portal hypertension. Let's talk about prehepatic portal hypertension. Portal or splenic vein thrombosis, increased portal flow, arteriovenous fistulae, massive splenomegaly in primary hematologic disease, leukosis, lymphoma, etc. Hepatic portal hypertension causes liver cirrhosis, hepatitis, congenital hepatic fibrosis. Colleagues, here you can see CT scan in liver cirrhosis and CT scan in gallstones in gallbladder. Here you can see gallstones. And here is liver cirrhosis. Can you see the screen? Is it visible? Okay, let's talk about syndrome of portal hypertension, post-hepatic portal hypertension. Causes of post-hepatic portal hypertension are hepatic vein thrombosis, Budd-Chiari syndrome, obstruction of inferior vena cava, cardiac causes, constrictive pericarditis, and restrictive cardiomyopathy. A clinical picture of portal hypertension includes symptoms due to portocaval anastomosis, dilation, ascites, and enlargement of spleen. A clinical picture, most important symptom in acute varicose bleeding, usually from the distal esophagus and fundus of stomach. More rarely rectal hemorrhages. Clinical picture. Here you can see a photo of patient with caput medusa. Is a symptom of varicose vein radiated from the umbilicus. A clinical picture. Ascites is accumulation of free fluid in abdominal cavity. Massive ascites may cause non-specific abdominal discomfort and dyspnea. Here you can see infographic of pathogenesis of ascites in patient with liver cirrhosis, portal hypertension. Usually, however, portal hypertension is inferred by the presence of hepatosplenomegaly, portal systemic encephalopathy in a patient with chronic liver disease. Here you can see infographic and portal hypertension, post-hepatic, intrahepatic and prehepatic portal hypertension. Diagnosis methods of syndrome portal hypertension. First of all, you have to check your patient ultrasonography. Next, you have to check Doppler ultrasound, reveals dilated intra-abdominal collaterals. Splenoportography is contrast technique to reveal obstruction of the portal vein. Hepatic encephalopathy is neuropsychiatric syndrome caused by liver disease and usually associated with portal systemic shunting of venous blood. A clinical picture of hepatic encephalopathy. Personality changes, usually impaired consciousness occur, drowsiness, confusion, stupor, and frank coma indicates increasingly advanced encephalopathy. A clinical picture of hepatic encephalopathy. A typical musty sweet odor of the breath called fetor hepaticus often occurs. A diagnosis of hepatic encephalopathy is based on clinical picture. There is no correlation with liver function test. Electroencephalography usually shows diffuse slow wave activity, even in mild cases, and may be useful in questionable early encephalopathy. Hypersplenism syndrome is a considerable enlargement of the spleen, characterized by anemia, leukopenia, thrombocytopenia, and hemorrhagic complications. Syndrome of hepatic insufficiency, a clinical syndrome of disorders in important function of liver due to the marked dystrophy and destruction of the hepatocytes. Causes of syndrome hepatic insufficiency, acute and chronic hepatitis, liver cirrhosis, tumors of liver, poisoning with hepatotropic chemical substances, or vegetable poisons. Classification of hepatic insufficiency. According to course, it may be acute and chronic. A clinical picture of compensated stage. Symptoms absent during early stage of hepatic insufficiency. Next stage, pronounced and decompensated. So there are many stages, many complaints. Fatigue, poor appetite, weakness, frequent dyspepsia, meteorism, pain in the abdomen, changes to loss of weight, edema, ascites, hemorrhagic diathesis, jaundice, and inadequate inactivation of estrogens by the chronically affected liver provokes endocrine disorders. Next stage is terminal dystrophic stage that ends in hepatic coma and death. One moment. So students, let's talk about terminal dystrophic stage that ends in hepatic coma and death. It is a third final stage. characterized by deeper metabolic disorders. Patients with chronic liver disease develop cachexia. A patient becomes easily irritable. His moods quickly changed. A specific tremor of the upper and lower limbs is characteristic. Pre-coma period may last from few hours to several days and even weeks. You can see features of hepatic coma. Liver may remain enlarged or its size may decrease. Patient's breath smells sweety hepatic. Inspection of the patient often reveals bleeding gums, nasal and skin hemorrhages, and jaundice. Kussmaul respiration. Motor anxiety, clonic convulsions. Next, laboratory test of syndrome hepatic insufficiency. Anemia, thrombocytopenia, increased erythrocyte sedimentation rate, increased level of bilirubin. Characteristic in the decreased content of substances produced by the liver, albumin, cholesterol, fibrinogen, prothrombin. Content of residual nitrogen and ammonia in the blood serum increases to indicate secondary affection of the kidney, hepatorenal syndrome. Hyponatremia, hypokalemia, and metabolic acidosis develop. Next condition is liver cirrhosis. Liver cirrhosis is chronic progressive disease characterized by increasing hepatic insufficiency in connection with dystrophy of the liver cells and diffuse disorganization of normal hepatic structure by regenerative nodules that are surrounded by fibrotic tissue. Diagnosis is based on clinical picture of the most characteristic syndrome, hepatosplenomegaly, portal hypertension, portal systemic encephalopathy, hepatic insufficiency, and also biochemical syndromes, cytolysis, cholestasis, mesenchymal inflammation, hepatocellular insufficiency, and biopsy. Students, you can take photo of the slide. So let's talk about minor clinical signs of liver cirrhosis. Is spider angioma, erythema of the palms, red lustrous lips, gynecomastia, xanthomatous plaque of the skin, hypocratic fingers. Inspection of the abdominal skin can reveal caput medusa and ascites. Coprology syndromes. Colleagues, you can take photo of the slide. It is very important. Changes of stool, coprology changes in different diseases. Gastric coprology syndrome. First of all, presence of undigested muscle fibers, creatoria, connective tissue, and vegetable fibers. Pancreatic coprology syndrome. Profuse discharge liquid excrements, polyfecalia, yellow-gray color, presence of natural fat, steatoria, creatoria, and star grains, amyloria. Bile deficiency coprology syndrome is characterized by gray color of feces, presence of fatty acids, stercobilin negative test. Enteral coprology syndrome is characterized by feces, yellow loose consistency, presence in feces leukocytes, epithelial cells, fatty acids, crystal solid proteins. Ileocecal coprology syndrome characterized by liquid foamy stool with acid smell, presence of mucus, cellulose, amyloria, and flora. Hepatocellular insufficiency syndrome is a decreased concentration in the blood substances synthesized by hepatocytes. Serum albumin, cholesterol, prothrombin, proconvertin, fibrinogen, serum cholinesterase. pseudocholinesterase syndrome. Cholestasis syndrome. Colleagues, you can take photo of these slides because it is very important syndromes. First of all, you can take photo hepatocellular insufficiency. Take photo of this slide. Next, syndrome of cholestasis is increased concentration in blood substances excreted in bile by hepatocytes, cholesterol, bile acid, bound bilirubin, alkaline phosphatase, gamma glutamyl transpeptidase, and copper. Have you taken the photo?
Yes.
Yes, ma'am.
Okay. Next syndrome is cytolysis syndrome. Cytolysis. Take photo of this slide. It is increased concentration in blood cytoplasmatic enzymes of hepatocytes. Aspartate aminotransferase, alanine aminotransferase, lactic dehydrogenase, and gamma glutamyl transpeptidase. Next syndrome is mesenchymal inflammation syndrome. Is increased content of various globulin fractions produced by reticulohistiocytosis cells of liver. Globulins, alpha, beta, gamma globulins, thymol turbidity test, and erythrocyte sedimentation rate. Next syndrome is acute pancreatitis. So let's talk about clinical feature. So typical presentation is with the severe constant upper abdominal pain, increased intensity over 1560 minus, which radiates to the back. Nausea and vomiting are common. There is marked epigastric tenderness, but in the early stages, guarding and rebound tenderness absent because inflammation is principally retroperitoneal. Patient becomes hypoxic and develops a hypovolemic shock with oliguria. Diagnosis is based serum amylase or lipase concentration and ultrasound or CT evidence of pancreatic swelling. X-ray should be taken to exclude other diagnoses such as perforation or obstruction, identify pulmonary complications. If available, serum lipase measurement are preferable to amylase as they have greater diagnostic accuracy for acute pancreatitis. Ultrasound scanning can confirm the diagnosis also in the earlier stages. The gland may not be grossly swollen. Ultrasound scanning is also useful because it may show gallstones, biliary obstruction, or pseudocyst formation. Next syndrome is chronic pancreatitis. Is characterized by fibrosis and destruction of exocrine pancreatic tissue. Diabetes mellitus occur in advanced causes because islets of Langerhans are involved. Around 80% of cases in Western countries result from alcohol misuse. In southern India, severe chronic calcific pancreatic occur in non-alcoholic, possibly as a result of malnutrition and consumption. Clinical features. Chronic pancreatic predominantly affect middle-aged alcoholic men, almost all present with abdominal pain. In 50%, this occurs episodes of acute pancreatitis. Also, each attack results in degree permanent pancreatic damage. Slowly progressive chronic pain without acute exacerbation affects 35% of patients. Chronic pancreatitis predominantly affect middle-aged alcoholic men. Almost all present with abdominal pain. In 50%, this occurs episodes of acute pancreatitis. Also, each attack results in a degree permanent pancreatic damage. Relentless, slowly progressive chronic pain without acute exacerbations affects 35% of patients. With the remainder have no pain but present with diarrhea. Clinical features of chronic pancreatitis. Pain is due to combination of increased pressure within pancreatic ducts and direct involvement of peripancreatic nerves by the inflammatory process. Pain may be relieved by leaning forwards or by drinking alcohol. Weight loss is common and results from combination of anorexia, avoidance of food because postprandial pain, malabsorption, and diabetes. Steatorrhea occurs when more than 90% exocrine tissue has been destroyed. Investigation in chronic pancreatitis. First of all, make a diagnosis of chronic pancreatitis, define pancreatic function, and demonstrate anatomical abnormalities prior to surgical intervention. Autoimmune pancreatitis is a form of chronic pancreatitis that can mimic cancer, but which responds to corticosteroids. It is characterized by abdominal pain, weight loss, obstructive jaundice without acute attack of pancreatitis. Pancreatic carcinoma. Men affected twice often as women, disease associated with increasing age, smoking, and chronic pancreatitis. Between 5 and 10% patients have a genetic predisposition. Clinical pictures. Many patients are symptomatic until advanced stage when they present with central abdominal pain, weight loss, and obstructive jaundice. Pain results from invasion of the celiac plexus and is characteristically very intensive. It radiates from the upper abdomen through the back and may be eased a little by bending forwards. Almost all patients lose weight and many are cachectic. Around 60% tumors arise from the head of the pancreas. Abdominal mass due to the tumor itself, a palpable gallbladder or hepatic metastasis is commonly found. Palpable gallbladder in jaundiced patient is usually a consequence of distal biliary obstruction by pancreatic cancer. Courvoisier sign. Thank you very much, students. Thank you very much. Thank you for watching, for studying today. And here your next lecture. Goodbye and have a nice day.
Thank you, ma'am. Have a
Thank
nice
you,
day.
ma'am, for the lecture.
Students who are leader of group, send me a list of students who were present today lecture, okay? From every group, groups 1, 2, 3, 4, 5, 6, 7, okay?
Okay, ma'am.
So goodbye and have a nice day.